Good afternoon, members. It is the appointed time. I call to order the meeting of the Bills Committee on the Electronic Health Record Sharing System Amendments Bill 2025. This is the fourth meeting. Now let's invite the administration to come in. The names of the officials are on the list. I will not read out their names. After the officials are seated, we will first look at the matters arising from the previous meeting. Now, the following papers have been issued by the Secretariat. List of follow-up actions required of the administration arising from the last meeting. That's CB brackets 3 766 2025 brackets 01. And the reply from the administration, that is paper CB brackets 3 766 2025 02. So the Secretariat has sent the two papers to members. When the officials are settled, I will invite the administration to walk us through the follow-up actions and the reply arising from the last meeting. Sam. Thank you, Chairman. Now, at the last meeting, members asked several questions. The replies are included in the paper. The member asked about the series of technical amendments to change the term 政府 or government to 特區政府, governments of the Hong Kong SAR. Some members asked, why didn't we amend the definition by way of amending Cap 1, Interpretation and General Clauses Ordinance? Now, as mentioned in the reply, under Section 3 of Cap 1, the Chinese translation of the term government is 特區政府. Now, in this bill, for the term government, the Chinese rendition is 政府, and that's not in line with the definition in Cap 1, so we will make a technical amendment to the bill. Now, in the reply, we have explained why this would enhance the clarity of the reference. If there are still any questions about our explanation, I will defer to the legal advisor for supplement. Now, at the previous meeting, members also inquired about some new concepts. So we have compiled a table to provide side-by-side comparison between the old and new references. So we have made an annex to explain some common concepts in the bill and also their relations with the original ordinance. So I refer members to the appendix. The third question is about the concern that's in the registration process of e-health. If a healthcare recipient chooses to deregister from the e-health, we will delete the data from the account. Now, there's worries that individuals with malicious intent would register and deregister repeatedly to disrupt the operation of the e-health. Now, we have conducted a research after the last meeting, and we have found that the number of withdrawal of healthcare recipients' registration or re-registration after withdrawal is insignificant. We will continue to closely monitor the situation and identify any irregularities. Now also, if the Commissioner for e-health record is satisfied that registering a certain individual may impair the security or compromise the integrity of e-health, he or she must not register the healthcare recipient on e-health. So in the future, if we identify any unaccounted for registration or re-registration on a repeated basis, we will take action and investigate proactively to protect the integrity of the system. That concludes my summary of the replies. Thank you. Concerning the administration's reply, do members have any questions? If not, then we will resume clause-by-clause scrutiny. We are scrutinizing the Chinese text of the bill. Now, at the previous meeting, we paused at clause 20 of the bill. That's cap 625, section 16 of the ordinance. That's 0027 on the markup copy. Now, because of time limitation on the last meeting, Ms. Carmen Kan was unable to ask question on clause 20. So I will first invite Ms. Carmen Kan to ask the question. Other members may also press the request to speak button. 4 minutes, questions and answers included. Ms. Carmen Kan. Thank you, Chairman. Now, page 27 on the markup copy. My question is, now there is a deeming approach. In other words, for a healthcare recipient or a patient, if the joining consent is given to join e-health, then they would be deemed to have given the sharing consent as well. Now, on the applicability of the provision, the amendment here is each specified entity. Now, subsection 5, definition of the specified entity, it means the Department of Health, the HA, the Primary Healthcare Commission, or a healthcare facility managed or controlled by the government, the HA, or the HA subsidiary. I think the drafting here is to provide flexibility to cater for future scenarios. So I seek an explanation from the administration. The deeming provision of sharing consents, does it only apply to organizations related to the government? What is the relations between this and the streamlining of the consent mechanism? Erica? Please switch on Ms. Erica Lam's mic. Am I coming through? Thank you. Ms. Khan? Now, let me explain the spirit of the original provision. Under the original provision, there were the joining consent and the sharing consent. They are separate, and the HCP or the healthcare recipient must first provide the sharing consent before their record can be shared. Now, originally, after joining consent is given, the sharing consent would be deemed to have been given. So after joining the e-health, the HA and the Department of Health will have access to the health record, and they can share the record on e-health. Now, at present, there are other organizations managed by the government besides the HA or the DH. For example, there are the Chinese Medicine Hospital and the Chinese Medicine Training Center in the 18 districts. So these are important components of our public healthcare system other than the HA or the DH. So we seek to include them in the mechanism as well. Now, concerning the relations between this and the streamlined mechanism, they are the same idea. After joining eHealth, public organizations besides the HA and the Departments of Health will have access to my healthcare record, instead of me having to offer individual consent to each organization. So the Departments of Health and the HA were covered by the original provision. Under the deeming condition or the deeming approach, you are now only seeking to extend or expand the scope of organizations under the sharing mechanism. So is there any change to the joining and sharing consent mechanism? There is no change. After the law has taken effect, once the joining consent is given, the healthcare record in a private institution would be uploaded and shared by eHealth. But the healthcare recipient still has the power to grant access or deny access to a certain healthcare practitioner. But what's the difference between before and after the amendments? Now, before the amendments, to upload the healthcare data onto the eHealth account, the patient has to give consent to the private healthcare practitioner. Now, after the amendments, after a joining consent is given, the private healthcare practitioner may upload a patient's healthcare record onto eHealth. But the granting of access does not change. Thank you. Now we have come to page 28 of the markup copy, clause 21 of the Blue Bill. Let's resume there. Thank you. Now we are at clause 21 of the bill. These are technical amendments, amending Part 2, Division 5, heading, repealing system to substitute with eHealth system. 22, Section 19 amended, application by healthcare providers for registration. These are also technical in nature. We will repeal the word system in 19 brackets 1 and 2 to replace with eHealth system. Now, page 29 of the markup copy, we have an amendment. We will replace the term healthcare professional with Hong Kong healthcare professional. Now, Section 19 stipulates that healthcare providers in Hong Kong may apply to register under eHealth. The 19 CNF, these are bodies registered under the Residential Care Homes Elderly Persons Ordinance. They can register under eHealth on the condition that they engage a Hong Kong healthcare professional to perform duties. That's why we are amending the provisions. No question. Please continue. Clause 23, amending Section 20, registration of healthcare providers by Commissioner. Again, we are repealing the word system and substitutes with eHealth system. There being no question, Clause 24, amending Section 22, page 31 of the markup version. A series of technical amendments here. Now, the provision is about governmental departments which can register under the eHealth. So we are changing the term 政府 to 特區政府. And also we are substituting the term system with eHealth system, and also healthcare professional with Hong Kong healthcare professional.
Please continue. Now to Section 25 to Also, suspension of healthcare providers registration. Also, withdrawal of healthcare providers registration. Also, repealing Utong as substitute with Igin Tong. Page 32. Here we can see Section 24 amended. Also, replacing system with e-health system. If there are no questions on that, we can now turn to page 33. There are also a series of amendments on repealing Zhengfu and substituting it with Dakoi Zhengfu, and also replacing system with e-health system. We can now turn to page 34. 34, which is on cancellation of healthcare providers registration, also replacing system with e-health system. If members have no questions, we can turn to page 36. This is more of an important amendment. We are going to add in Division 6, recognition of non-Hong Kong healthcare providers. If members recall, we are going to give authority to non-Hong Kong healthcare providers as long as they comply with certain requirements. And so on the requirements set out, you would see that these are the requirements to be satisfied by non-Hong Kong healthcare providers. A, if the commissioner believes that the healthcare provider is a healthcare provider for the e-health system, then that person can be recognized. And then we set out requirements in subsection 2. Some of them are requirements specified for connecting the healthcare provider to the e-health system, and also system requirements on data sharing, such as on data formatting. And subsection 3, that they can only be recognized if they satisfy certain requirements. A, the healthcare provider can only provide care if it's licensed or permitted to provide healthcare. And the healthcare provider should not impair the security or compromise the integrity of the e-health system. And with the consent of the commissioner can then notify the healthcare provider in writing of the decision, the date on which the recognition takes effect, and the conditions for the recognition. Ms. Doreen Kong, thank you. Well, this is a drafting issue. I would like to refer you to 26A3. There are two circumstances in which we cannot recognize the healthcare provider unless the commissioner is satisfied with those conditions. So here we must prove that the commissioner is satisfied with those requirements. For these two circumstances, if we write it this way, as it is listed out now, it seems that we cannot recognize them because we're now asking the commissioner to give evidence to recognize the provider. It's actually very simple to see whether the provider has been providing healthcare in a place outside Hong Kong. We want to protect the interests of Hong Kong people. Why do we actually require the commissioner to set out proof or evidence? Thank you, Ms. Kong, for your question. Let me try to address this question. Well, let's say we're not talking about non-Hong Kong healthcare providers. For local healthcare providers, of course, there must be certain vetting made. We would go through the system and ensure that the healthcare provider actually complies with registration requirements. E-health is a very important system, and within it data of the people in Hong Kong. Therefore, the commissioner must ensure that these persons satisfy certain requirements for non-local healthcare providers. The providers may actually provide us with evidence to ensure that they are permitted to provide healthcare in that place under the law of that place. And we also have a team to evaluate the security of the system. The commissioner must do something. It can actually be an interactive process to ask the other party to provide proven evidence. And if we doubt that, then we would not recognize the healthcare provider. Ms. Kong, do you have follow-up? Yes, I'm not asking you about recognizing the healthcare provider. I'm asking about when you do not recognize the provider. The commissioner must do something to be satisfied. I'm not concerned with the recognition part. My question is, if they're not able to fulfill A and B, why can't we just say that we don't recognize them? Why do we have to set sort of like a threshold that the commissioner must be satisfied? Or I'm asking about the situation or circumstance in which the provider not being recognized. Well, we cannot recognize a person if the commissioner is not satisfied with these two requirements, because we want the public to know that e-health is very important, and we would not allow health providers not licensed or not permitted to provide health care to provide service in Hong Kong. I'm sorry, Chairman. I don't think you understand my question. Let us look at the English version. It says here, however, the commissioner must not recognize a healthcare provider if, and you just list out A and B. Why do you have to include the phrase "the commissioner is satisfied"? I'm asking about a drafting issue. Can you take a look at the English? Why can you not make it simple? Why do you have to add "the commissioner is satisfied"? That because by putting in this phrase, let's say I'm not a good provider. What do you mean by the commissioner being satisfied? I think that if you just say the commissioner must not recognize a healthcare provider if A and B, that would be sufficient. You really don't need to add the phrase "the commissioner is satisfied." Ms. Kong, I'd like to defer to the law draftsman. Thank you, Chairman. Thank you, Ms. Kong, for your question. The drafting is actually similar to the existing ordinance. The commissioner, under Section 20, the commissioner can allow persons to be registered under the system, and if you see marked up copy, page 38, there's actually a suspension of healthcare providers' recognition if the commissioner is not satisfied. If the commissioner finds an occurrence and decides, then the provider may not be recognized. We want the drafting to be consistent, and the ultimate decision lies with the commissioner. I hope that this answers your question. I think Ms. Kong's question is that if you include the phrase "the commissioner is satisfied," it sorts of actually leads to whether the commissioner believes in that, and you're leaving the judgment to the commissioner. And you're saying that there's also a judgment responsibility for the commissioner for local healthcare providers as well, or in existing legislation. Well, the intent is actually to enable the commissioner to have this judgment. Well, I'm actually trying to help the commissioner because the commissioner seems to have an extra responsibility. No, it's not only this circumstance. I think that you see that in other legislation as well. We understand the intent, but perhaps you could go back and think whether you should amend the drafting. Ms. Lamso, why? Thank you. I would like to follow up on 3B on and when the recognizing the healthcare provider may impair the security or compromise the integrity of the e-health system. Compromise, impairing the security. What is the definition of that? Would you actually have a look at their track record, or how actually do you define that it impairs the security? Thank you for your question. When we're interfacing different systems, then HA will actually set up certain requirements and principles. For example, how the operations and procedures should be done, and when you're managing the data access, how do you monitor the mechanism? When loopholes are identified, what the procedures would be. So all these are procedural matters in which we would review. There would also be requirements on the systems. When a person accesses the data, there must be 2 passwords to be entered to enhance security. So these are the requirements we would consider. We would draw reference from security requirements on current health systems, and then see whether these providers can actually meet those requirements. Chairman, are there any guidelines or protocol on this security impairment, or are you actually drawing up a legislation on this at the same time? Thank you, Chairman. Thank you for your question. Currently, we are trying to take in previous experience. We are drawing up plans to work with other health providers outside of Hong Kong. So we actually do have experience on that, and we are learning from it. For non-local healthcare providers, we are drawing up relevant requirements, and this would be done at the same time. Security would be an important part that we would consider at a later stage. Our chairman would like to consider. Well, we see a recent example that in the Greater Bay Area, in which there are healthcare providers for people of Hong Kong, but then as of today, they're still not sure whether e-health could be operated there, or whether there would be confidentiality in their data. I hope that there is actually a timetable to show us, because they're really service providers reflecting their zero knowledge on e-health. So you are concerned that this may impair the security and integrity of the e-health system. Well, yes, because some of the non-local health providers do not know how to handle the system. They actually have zero knowledge on that. Well, I think we should ensure that healthcare providers and also the rights of patients. I hope you could follow up on that. We have guidelines for local healthcare providers, right? Well, thank you, Chairman. Thank you for your question. Let me try to supplement. A member should remember that we actually before adopted the cross-border health operation, and we actually work with some healthcare providers in which we set out guidelines and protocols for them to follow. I think that when we are cooperating with them, we had the IT team sent in to ensure that their system fulfills our security requirements as well. Under the health vouchers for the elderly, I think we already know about the systems, but when we're expanding new systems, well, if we participate in cross-border cooperation, we would also ensure that there would be stringent and strict regulations to ensure that our health providers comply with those requirements.
Dr. David Lam, thank you. Well, I see a lot of people wearing a face mask today, so I wish you all good health. I have a question about Section 26A. In the future, will the Commissioner have to approve or scrutinize the application to register under eHealth by non-Hong Kong healthcare providers? And I want to clarify something. Now it says that whether an application is made, the Commissioner will conduct a check. So it says if the Commissioner is satisfied. So it seems that the Commissioner will have to make a judgment. The healthcare provider has to provide certain information to satisfy the Commissioner. So the burden is on the applicant or the healthcare provider. So there is a discretion to be exercised by the Commissioner. They may or may not grant the approval. So maybe we need to spell out the standard in the code of practice. Now, subsection 3, if the Commissioner is satisfied about certain conditions, then they may not recognize the healthcare provider. So this is not part of the approval process. If the Commissioner finds certain issues during the process, then the Commissioner will have to prove and the existence of these conditions. So the burden is on the Commissioner. Thank you. Members have asked similar questions about the process of recognizing non-local healthcare providers. Now, first of all, for local healthcare providers, having met the conditions, the healthcare provider can make an application to the Commissioner, and then the Commissioner will approve the application. So for refusals, the Commissioner will have to notify the applicants of the reasons and grounds for refusal. For non-local healthcare provider, it is different. The non-local healthcare providers will not be the party to file an application. Instead, the Commissioner will take the initiative to invite non-local healthcare providers to register in eHealth. So the Commissioner will judge whether the system of these non-local healthcare providers can be linked with the eHealth in selecting non-local healthcare providers to invite. Since this is not a process of application made, there is no issue of refusal or acceptance of the application. Thank you. Let's continue. Pages 36 and 37 of the markup copy. Page 37, Clause 26, Section 26B, withdrawal of non-Hong Kong healthcare providers recognition. A recognized non-Hong Kong healthcare provider may request the recognition to be withdrawn. However, the request must be made to the Commissioner in the form and manner specified by the Commissioner. After granting the request, the Commissioner must notify the healthcare provider in writing. Afterwards, the non-Hong Kong healthcare provider will no longer be a registrant under the eHealth, and the sharing consent will be withdrawn immediately. Mr. Ring Kong, just a simple question. Upon withdrawal, the sharing consent is void, but the non-Hong Kong healthcare providers might have come across some patient's data when the recognition was still valid. So how do we address these cases? Ms. Erica Lam. Now, usually, the non-Hong Kong healthcare provider would have to log on to a panel and then gain access to the healthcare data upon the consent from the patient. Now, for those records related to the treatment, then the healthcare provider might copy those records onto the system. For these cases, we have no jurisdiction. However, after the recognition is withdrawn, then the non-Hong Kong healthcare provider can no longer log on to eHealth, and they will have no access to the patient's data. But Chairman, it is possible that the healthcare providers might have extracted the data and copied it onto their system. But that is their own system. Is equivalent to entering the clinical data into their own system themselves. That's my understanding. Then would the administration take a further step to protect patients? I understand that I have given consent to recognize non-local healthcare provider to look at my healthcare record. However, can we have them can we impose a condition that they must obtain a separate consent to extract my data from the system? Will you implement this additional safeguard to protect patients' rights? Erica. Thank you. If I log on to eHealth, I cannot simply extract the entire record and duplicate it on my system. Now, example is, if I'm a doctor in the Greater Bay Area, before prescribing a medicine, I need to check for allergies. Then in prescribing the medicine, I might put it on record that the patient has allergy of a certain medicine. That's why I'm not prescribing the medicine to the patient. So for information extracted from the system, which is related to my clinical treatment, I would put it on my own record and make it part of my record. But it would be impossible for just any doctor to log on to eHealth and extract and copy patient's record. Under the legislative framework, that is not allowed. But I thank Ms. Doreen Kong for her questions. No other question. Moving on to page 38. Section 26C, suspension of non-Hong Kong healthcare providers' recognition. Now, the Commissioner may suspend the recognition of a non-Hong Kong healthcare provider if they reasonably suspect that the healthcare provider contravenes a condition for the recognition or no longer complies with certain requirements, for example, the system requirements, or that the healthcare provider is no longer licensed or otherwise permitted to provide healthcare, or that the recognition may impair the security or compromise the integrity of the eHealth system. Now, for these scenarios, the Commissioner may suspend the recognition for a period of not more than 28 days. In doing so, the Commissioner must issue a written notice to the healthcare provider and notify them of the reasons for suspension and the suspension period. However, during the suspension, the healthcare provider can still upload new information onto eHealth, but they cannot have any access to the existing health record on eHealth. Now, when the Commissioner is satisfied that there are no longer any grounds for suspending the recognition, for example, if the system security is improved, then the Commissioner must notify the healthcare provider in writing of the decision to lift the suspension and also the date on which the suspension ceases to take effect. Now, the system is similar to that of Hong Kong healthcare providers. When the commissioner suspects any contravention of the requirements, the commissioner can suspend the recognition for local healthcare providers. Mr. Ring Kong. I wonder if this question was asked last time. Subsection 4A. During the investigative process, the healthcare provider may still upload data onto eHealth. However, when the recognition is revoked, the healthcare provider can no longer upload data onto the system. Now, when there is suspicion of practicing without license, then why are you still allowing the healthcare provider to upload healthcare data during suspension? This is just a very short interim of 28 days. Why are you allowing suspected unlicensed healthcare providers to upload healthcare data onto the system? How can you ensure the accuracy of those data input? Thank you, Chairman, and thank you, Mr. Ring Kong. Now, that is a stage when the Commissioner is still suspecting whether there are contraventions. So the recognition will be suspended for investigation purpose, but the recognition has not been formally withdrawn yet. So we want to ensure comprehensiveness of the patient's health data, so we are still allowing the upload of healthcare data. So despite the suspicion, you are still encouraging the patients to see the doctor. Even when you are carrying out an investigation, you are still encouraging the patients to consult the doctor. Now, the patients may not be aware of our investigation ongoing, but during the treatment process, health record will be generated. Now, if the investigation proves that the contraventions are non-existent, then upon confirming that the healthcare provider is still a licensed body, we can ensure the comprehensiveness of the data. But that's very strange. You are allowing the healthcare provider to upload the data but not have access to the data. According to 4B, the healthcare provider cannot retrieve the data. Then the doctor will know that they are under investigation. So I don't see how this works. During suspension, we would like to impose some handles for the healthcare providers to have limited access to the eHealth system as a sort of warning. However, during the interim, to ensure the comprehensiveness of the patient's health data record, we don't want the patient to miss out any healthcare record in their account. So that's why we are still allowing the healthcare providers to upload the health data of the patients onto eHealth. Now, whether it is consistent with the treatment for local healthcare providers, this is still very strange. The investigation will carry on for some 3 months. So in the process, I cannot access the healthcare data of patients. So how am I supposed to treat the patients? Now, the investigation cannot go on forever. So the first suspension cannot last more than 28 days. Now, if more time is needed, under subsection 2, the Commissioner can further extend the suspension period for no longer than 28 days. So there is a time limit for the commissioner to complete the investigation during the period. Now, if conditions are found that warrant revocation, then the recognition will be revoked.
主席佢解答唔到，不過我提。
Chairman, she's not able to answer my question, but I just want to raise this question. If they think that it's all right, it's all right. I just think that it is a very strange way of handling it. So if it's a temporary suspension, if there are special exemptions, let's say it's due to very serious incidents, even though you don't 100% prove, can the commissioner also suspend the registration of new data or information? If we believe that it is already very serious, then we would just suspend the person immediately. It would not be a temporary suspension. A suspension is when we do have reasonable doubt and we want to conduct an investigation. Thank you. All right, let's continue. Page 40, 26D, on revocation of non-Hong Kong healthcare providers recognition. The commissioner may revoke the recognition of a non-Hong Kong healthcare provider if the commissioner is satisfied that the healthcare provider contravenes a condition for the recognition, the healthcare provider no longer complies with the requirements specified by the commissioner, the system requirements on data sharing specified by the data, the healthcare provider is no longer licensed, or the recognition may impair the security or compromise the integrity of the health system. So the commissioner must notify the healthcare provider in writing, and the healthcare provider may, within 40 days after the date of the notice, make representations to the commissioner to object to the revocation. The commissioner must not revoke the recognition unless the healthcare provider has not made any representations or the commissioner has considered representations and informed the healthcare provider of the decision of revocation. Dr. David Lam. Revocation does not need to go through suspension, right? Yes. All right. Let's continue. Now, Division 7, recognition of non-Hong Kong information infrastructures. It is in line with the existing infrastructures we went through earlier. Earlier, we mentioned that there would be some circumstances that there are similar systems to e-health across the world, and we have seen systems that could be recognized. And through these systems, healthcare providers may make use of those systems to provide a service to people in Hong Kong. So first of all, there is Section 26E that the commissioner may, if satisfied that a Hong Kong and non-Hong Kong information infrastructure complies with the requirements set out, it can recognize the information infrastructure for connection to the healthcare system. There are circumstances in which a commissioner must not recognize the information infrastructure. That is, if the infrastructure is operated by the government or an authority of a place outside Hong Kong, and the information infrastructure is being used or to be used to keep the personal particulars of healthcare recipients who receive healthcare in that place. And if these requirements are not met, then the commissioner must not recognize the information infrastructure. And if the information infrastructure may impair the security or compromise the secretary of the e-health system, then the commissioner could choose not to recognize it. And then the commissioner must also notify the operator of the information infrastructure in writing. There will not be any applications made. The commissioner will, through review, kick off the entire procedure in recognizing the information infrastructure. Ms. Carmen Ken. Thank you, Chairman. I'm sorry, I'm a bit slow. I'd like to go back to 26B and D. D is 26B for the withdrawal of non-Hong Kong healthcare providers recognition. So this application is made by the non-Hong Kong healthcare provider. Am I understanding this correctly? And then for 26D, the revocation process is actually kicked off by the commissioner. Yes, 26B is on the initiative of the healthcare provider, and 26D is actually led by the commissioner. Yes, so for the shared consent here, whether it be withdrawal or revocation, it will immediately come into effect. Would the healthcare recipient know about the ineffective shared consent? You'll be able to find on the app the registered healthcare providers. So if you have given shared consent, you'll be able to see which providers you have offered to give consent to. And when we are adding in non-Hong Kong healthcare providers, we will try to highlight it so that locals would know about it. Yes, I hope that there will be a better design, a simple and good design for people to understand it clearly. Because for 26D, it is on the initiative of the commissioner, and the recipients may actually not know about it unless you notify them. Thank you. Ms. Doreen Kong. Well, on page 42, 3A, the information infrastructure must meet 4 requirements. I'd like to ask about 3. The information infrastructure enables the data and information captured to be used and shared for facilitating the provision of healthcare to the healthcare recipients. Can you explain to me who's actually using it and who it would be shared for? Because you said kept in it to be used and shared. So amongst whom are you talking about? Erica, thank you for your question. We're talking about the nature of the information infrastructure. We hope that the nature of this would be similar to e-health. And so in B, we were collecting health data of the healthcare recipients, and this information can be used and shared. So for whom? Of course, we're talking about healthcare recipients. And when we're providing services to recipients, then we would need to be some sort of shared amongst them. And these patients would actually be people of Hong Kong who are seeking such service, and through this service, they will need to have their data shared so that the healthcare providers could provide them with such service. Only those infrastructure could be recognized. Chairman, please do not forget that under 3 here, that if this criteria is not met, then the commissioner must not recognize the information infrastructure. When I asked about it, it took a long time for you to explain. You were saying that the data, well, let's say it's a medical organization. Are you talking about the data to be shared within the organization or within the city or within Hong Kong? It's not very clear. So when you need to understand whether it's a information infrastructure, you need to make clear who you are sharing the data with. This is very important. Thank you for your question. In 3A3, we said that we are talking that they need to meet a certain target, which is to actually to facilitate the provision of healthcare to the healthcare recipients. And then we hope that by using this sentence, we'll be able to make it clear. Well, using to be used and shared between the institution or the provider, then it would be clear. I just want you to confirm this. Well, other countries may also adopt a similar system, and I think that it could also be applied there. Well, you can make further clarifications of this later on. Mr. Holden Chow. Thank you, Chairman. Well, what about when you are actually operating the system? For non-local information infrastructure, well, simply put, this infrastructure is not in Hong Kong but elsewhere or overseas. Under 3B, well, if the information infrastructure may impair the security or compromise the integrity of the e-health system, then the information infrastructure would not be recognized. Well, if that's the case, of course, we must revoke the recognition. But then I see that in Section 4 that when the commissioner decides to recognize the information infrastructure, the commissioner must then notify the operator in writing of the decision, the date, and the conditions for the recognition. Does it mean that you know that the information infrastructure may impair the security, yet you still need to allow them 2 or 3 weeks before suspending operations? Or can you make it clear that if there is an issue, then you can actually revoke the recognition immediately? Well, this is only the notification. If there's actually impairment of security, then of course it would be revoked, right? Well, yes, let me try to make it clear. Talking about a recognition, the commissioner can only recognize a system when the system has met certain requirements. And the infrastructure cannot impair the security or compromise the integrity of the e-health system. When it is found that the system is safe and not compromise the integrity of the e-health system, then the commissioner can then recognize it, and then the commissioner must notify the operator in writing. But let's say, as Mr. Holden Chow said, there are certain security loopholes in the system. The commissioner can then revoke the recognition. We will mention it in the other clauses later on. Ms. Doreen Kong. Chairman. Well, 3 is actually long and winding. Section 3. Let me read it out in English. However, the commissioner must not recognize the information infrastructure if the commissioner is satisfied that A, and then B, you also say recognize the information infrastructure. I would like to ask in the Chinese, what's 認可該設施免可能損害醫健通系統的保安或危害其完整性。What do you mean by 認可設施免可能損害? Can you explain to me what the Chinese actually means? Thank you for your question. Well, we could try to make the Chinese version more succinct. Our original thought is that when we want to recognize a system, but we know that there are certain security loopholes, and by recognizing the infrastructure, it may impair our security. Under that circumstance, the commissioner must not recognize the infrastructure.
Chairman, if I may. So you are saying that the commissioner would like to recognize the system, but it is found that it may harm the integrity of the e-health system upon recognition of the system. So can you please rewrite the Chinese sentence? It is really poorly drafted. We will leave it to the administration to amend the drafting of this sentence. (26F) Withdrawal of recognition of non-Hong Kong information infrastructure. Non-Hong Kong information infrastructure operators can apply for the withdrawal of recognition with a request made to the Commissioner in the form and manner specified by the Commissioner. And the Commissioner will issue a written notice detailing the dates on which the request is granted. And upon the grant, the sharing consent would be invalidated. Dr. David Lam. Mr. Holden Chow reminded me of an issue. Now, whether it is recognition for a non-local healthcare providers or the withdrawal of recognition of non-Hong Kong information infrastructure, the requirement is that the Commissioner must issue a written notice to the healthcare provider, and within 14 days, the healthcare provider can make a representation to protest. So unless the Commissioner is denying the representation within 1 day or 2 days, then the 14-day suspension is a must. Can the administration clarify? Thank you. It depends on what action is taken to uphold the integrity of the system. Let's say a non-Hong Kong information infrastructure operator has the system hacked, then we would have break up the connection with the system immediately. Now, if the system is compromised to an extent that it is irreparable, then we will withdraw or revoke the recognition. Then we will remove the name of the operator from the recognized list. The sharing consent will be revoked, and the record shared will be deleted. So by a withdrawal or a revocation, it entails a series of actions. From a security point of view, if we identify a systematic risk, we will sever the connection between these systems immediately so that it will not affect the integrity of the e-health. Before you can withdraw or revoke the recognition officially, it seems that the recognition is still there. So would it be problematic if you sever the connection? According to the law, I know you should sever the connection, but it seems problematic from a legal point of view. Now, if I do this simultaneously, I'm revoking the recognition and severing the connection simultaneously. Then after 14 days, after hearing the representation, I can officially sever the connection and revoke the approval. So there seems to be some technical issues here. According to the law, before the revocation, you are still allowing the healthcare provider to upload the healthcare data of the patient on the e-health. Does it mean that you must keep the connection between the systems intact before the official withdrawal? Administration. Thank you. As I've mentioned, there may be many reasons behind which the Commissioner must withdraw the recognition. For example, if the Commissioner suspects that the healthcare provider is no longer licensed, then actions will have to be taken to verify the situation. So it does not relate to the connectivity with the system. But if the system's integrity is compromised, we can take immediate action to sever the connection. Now, in a subsequent chapter, the bill provides for the power of the Commissioner to take actions to protect the integrity of the e-health. Ms. Carmen Khan. I'm also following up on Dr. Lam's question. I think Ms. Erica Lam was referring to Section 26H about the revocation of recognition of non-Hong Kong information infrastructure. So 26D is about withdrawing the recognition for the healthcare provider. Now 26E and H seems to be comparable provisions. A 14-day period is given for representation to be made. However, under 26H, you can't withdraw the recognition immediately unless the infrastructure operator denies to make a representation. So I think when we have come to 26H, we need to consider whether the commissioner should be given the power to revoke the recognition immediately. After all, we're talking about connectivity between a non-local infrastructure system with the e-health, an important piece of infrastructure in Hong Kong. It may jeopardize the security of e-health or undermine the integrity of the system. But there is a pathway for making representation. You have to wait 14 days. And also, the commissioner must consider the representation first before deciding to revoke the recognition. So we're still on the issue of revocation of recognition. So can we briefly explain Section 26H here? Now on the written notice, we will specify the date on which the revocation takes effect. So if the situation is egregious, the commissioner can impose a revocation immediately, to take effect immediately. And if there are no representation within 14 days, then these healthcare providers or the infrastructure operator will be removed from the list officially. Now let's resume the clause-by-clause scrutiny. Now we are now at 26G, page 44, suspension of recognition of non-Hong Kong information infrastructure. That is related to the suspension of recognition of non-Hong Kong healthcare providers. If the commissioner reasonably suspects that the operator has contravened certain condition and is no longer complying with the requirements for system connection, and fail to meet the descriptions under the requirements, for example, used by the local government for storing local health records, then the revocation may take place. Now, if the commissioner considers it appropriate, the commissioner may impose a suspension and extend the period of extension by no more than 28 days by notice in writing. If further extension is needed, the commissioner may also do so by writing. Now, on the notice, the commissioner will notify the provider, the service provider of the suspension, the date on which the suspension takes effect, and the reasons for the suspension. Now, during suspension, new data or information can still be provided by the healthcare recipient. However, the information infrastructure operator can no longer gain access to the record on e-health. If the commissioner is satisfied that there are no longer any grounds for suspending the recognition, then the commissioner will issue a notice in writing and notify the service provider of the date on which the suspension ceases to take effect. Mr. Ring Kong. Now, just now we were talking about healthcare providers. 26G is about information infrastructure. Now, like other members have said, It has to do with the security and the integrity of the e-health system. So for extreme cases mentioned by my colleagues, if the system is in danger and you are still investigating the case, shouldn't we prohibit the infrastructure operator from uploading new data? Like Ms. Carmen Can said, we should consider removing the 14 days representation period. We need some safeguards to guard against extreme scenarios. Still on revocation or suspension of recognition. Now, for egregious cases, we will not suspend the recognition. We will invoke Section 26H to revoke the recognition directly. So why don't we simply remove the provision about suspending the recognition? Why do we need a suspension mechanism when you can revoke the recognition directly? I think what we are asking the administration to do is to provide for extreme scenarios. For example, under 26H, we will deprive the providers from the 14-day representation period and no longer allow the provider to upload new data. But I think the administration is considering scenarios like false alarms. Administration, thank you. Exactly, we are considering various scenarios. There are cases which are less serious in nature. There may be a report of a system under attack. The Commissioner may reasonably suspect that it may affect the e-health system's integrity. So for these scenarios, we will suspend the recognition when the system has not caused any harm on the system. However, for risky cases, if we consider that it is not just a false alarm, the connectivity will really pose an issue, then we will not invoke 26G, but rather revoke the recognition immediately to safeguard our system. Mr. Rin Kong. Now, sometimes things happen in the split of a second. So shouldn't we err on the safe side? I think you are being too lenient in the bill. We're talking about personal data. Shouldn't we keep the gate more stringently on behalf of patients in Hong Kong? And also, it takes time to investigate. If you ask me, I think the administration is striking a balance here. We can't rule out the possibility or necessity to connect our system with the information infrastructure in other places. There are sometimes false alarms. So if every time when there is a false alarm, you are revoking the recognition and severing the ties, it may harm the patient's rights because new data cannot be uploaded. So I think there is a balance to be struck. It depends on how severe the cases are. The judgment is to be made by the Commissioner. Thank you, Chairman. That's our intent. But we understand Mr. Rin Kong's concern. We will study how we can make the provision clearer to specify that for serious cases, the Commissioner must take immediate action to safeguard personal data. Yes, several members have raised similar concerns. Thank you.
Moving on to 26H. Oh, I'm sorry. Dr. David Lam, you have a question. Oh, it's already been answered. Page 45. Revocation of recognition of non-Hong Kong information infrastructure. So these would be more serious situations that the Commissioner already is satisfied that the operator has contravened a condition for the recognition, or that the information infrastructure no longer complies with the requirements, and the commissioner may then revoke the recognition. The operator can, after receiving notice from the commissioner, make representations within 40 days after the date of their notice, and the commissioner must not revoke the recognition unless the operator has not made any representations. The commissioner considered representations and informed the operator, and that a sharing consent given in relation ceases to have effect once the revocation takes effect. Ms. Carmen Ken. Well, one is related to the infrastructure, one is related to the system. I hope that you can really go back and take a look at 2, 3, 4. Well, not everyone can explain it very clearly. When we are reading it, look at bracket 4. The commissioner must not revoke the recognition unless something happens, and there may be a chance that you have to wait 14 days for the operator to make representations, or that the commissioner can only revoke the recognition after considering the representations. You should provide at least a date. You may notify the operator on the same day as when the operator is making the representation. I want you to go back and look at 2, 3, 4 to allow representations from the operator, and at the same time, when there are special circumstances, the commissioner has the discretion not to provide you with the 14 days of the immediate revocation. I believe you should give some time for representations unless it's a very serious offense. Well, a few members have already asked the same question. Administration, do you have any supplement? If not, can you please go back and see whether there is a need to amend this? Yes, thank you. We would go back and try to see how we can address everyone's concerns. I would also like to take the opportunity to follow up on a question raised, which is on the code of conduct. Under the current legislation, the commissioner can issue code of conduct. We do provide those to local healthcare providers on procedures, on operations, on best practices, etc., so that the operators will follow and abide by the requirements. Well, under the existing legislation, the commissioner can also suspend the registration if there is reasonable doubt on, and one of the grounds may be that the healthcare provider has contravened the code of conduct. The legal advisor has asked whether this would also be applicable to non-local healthcare providers. Our thinking is that when we recognize the non-Hong Kong healthcare providers, we would list out certain requirements. If we believe that certain requirements under the code of conduct could be applicable to non-Hong Kong healthcare providers, any contravention would lead to a suspension or revocation of recognition. Therefore, we did not highlight this of a contravention of code of conduct under the amendments. Thank you. Dr. David Lam. Thank you, Chairman. Just a suggestion. You have given authority for the commissioner to take immediate action and cut off all ties to the information infrastructure. Well, if you do that now, it may lead to legal proceedings. So I believe that you should list this very carefully in the legislation. I think you should provide your response in writing to us at the next meeting. Mr. Toden Chow. Oh, thank you, Chairman. I'm sorry, I just have one more question. The contravention of code of conduct. Oh, let's say there's a contravention and that would lead to revocation. Am I correct? Would that also go under 26H? That when you revoke the revocation, there will still be 14 days of representations? I just want to verify if that's the case, that we will follow the same mechanism, that there will be a 14-day period for representations to be made. Thank you for your question. Yes, it's consistent. The legal advisor asked whether the code of conduct is not listed here as grounds for suspension. It is because we would actually put these under the requirements under the code of conduct, and so we do not need to make this explicit under the current bill. The revocation process, however, would be the same. There would be 14 days of representations. We have heard members' concerns. We're going to go back and see whether there are any ways to make this clearer and to better protect our interest, that if there are serious issues, then we will be able to revoke the recognition immediately. All right, we'll wait for a response in writing for that. All right, let us now move to Division 8. Clause 28, adding in Division 8, medical documents and signatures on medical documents in electronic form. Let me give you some background information. More and more people are using e-health system, and so we want to set up a clear framework for the electronic records to be protected under the law. And to clarify our development of the e-health system. Now, let us first take a look at 26I. This is the interpretation of Division 8 of Part 2. There are definitions on issue in relation to medical document, include making or giving the document. Electronic record, it has the meaning given by Section 2, Bracket 1 of the Electronic Transactions Ordinance. And also a definition on medical document. It means a document issued by a healthcare professional or healthcare provider that relates to the health condition of or to the healthcare provided or to be provided to a healthcare recipient. All these would be considered as medical documents. Also, we also added in the Advanced Medical Directive. Well, this is very clear because that might mean not giving medical treatment. And so we want to include that under medical document as well. There are no questions. We can now take a look at 26J. And requirement for writing is satisfied through e-health system. If an ordinance requires or is regarded to have required a medical document to be in writing, the requirement for writing is also satisfied if the medical document is in the form of an electronic record that is issued or authenticated through the e-health system. However, if the effect of this cannot be complied due to the operation, then it does not apply to the ordinance because there are some subsections that may be in conflict of interest. And under those circumstances, the effect of the subsection will not apply to that ordinance. And now we're moving on to 26K. if an ordinance requires the signature of a person on a medical document, such as an advanced medical directive, and if the signature of a person on a medical document is in electronic form, then the requirement is satisfied. And that this is verified by the e-health system. However, if the effect of subsection is such that any requirement cannot be complied with due to the operation, then the subsection 1 would not apply to the ordinance with respect to the requirement for signing. 26L, a requirement for original form is satisfied through e-health system. E-health system issues and authenticates original forms. However, if the effect cannot be complied with, then it will not be applicable with respect to the requirement for original form. Please wait. Dr. David Lam, thank you. Thank you, Chairman. Does it mean that medical prescription after the passage of the legislature would not need paper form, and would you also need to amend that legislation as well? Thank you for your question. You are correct. We would look at the requirements on prescription. If there are conflicts, then we would need to make slight amendments to the legislation. For those without conflicts, and it would be applicable immediately, because prescriptions made through the e-health system could be recognized. An easy example would be the DNA CPR. The Advanced Medical Directive states clearly that this cannot be issued through electronic form, and so that would not be applicable under the e-health system. All right, let's continue. And now to page 50, 26M. That if an ordinance requires that a medical document to be retained in a form that is stipulated in the ordinance, the requirement is satisfied by retaining in the e-health system, if that is in form of an electronic record that is issued or authenticated through the e-health system. However, the effect is such that the requirement cannot be complied with due to the operation, then it will not apply to the requirement for retention. 26N, that there may actually be conflicts and within the sections, and now this time these sections would prevail over the electronic transactions ordinance to the extent of conflict or inconsistency. 26O. Under certain circumstances, we foresee that certain medical documents may become invalid if not issued through e-health system, and that we might not accept paper forms of certain medical documents. We want there to be a clearer supervision and monitoring of certain medical documents. Therefore, under 26O, we stated very clearly that a medical document specified in Part 1 of Schedule 2 issued in the form of electronic record is invalid unless it is issued through the e-health system. So this has nothing to do with the paper records. Subsection 2, a medical document specified is invalid if it is not in the form of an electronic record or not issued through the e-health system. What we mean by that is that we foresee that some documents can only be issued via the e-health system, and so we will not accept any paper forms. We would look at a Schedule 2 later on. Schedule 2 is now empty. In future, when we need to apply this clause, then we would make amendments to the bill.
Mr. Ring Kong. Chairman, may I seek a clarification from the administration by way of examples? Now, as you said, Schedule 2 is now non-existent. So we were quite confused about paper form or non-paper form medical documents. So what are some examples of documents you are going to include on Schedule 2 so that we can have an idea? Now, an example under 26.0 where medical documents must be issued through e-health system in electronic form. One example is advanced medical directives. Now, in the future, we will allow for both paper-based and electronic form AMD, but for electronic form, the document must be issued through e-health system. So we will include AMD on Schedule 2 of the Part 1 of the ordinance. Now, for some situations, we are only going to accept electronic medical documents, but that depends on the developments of the trade. One day in the future, maybe all prescriptions will have to be issued through an electronic system. So it will be done by way of e-health. But that really depends on whether the trade is ready and whether the technology is ready. So it remains to be seen in the future. I'm just making sure that you would consider the views of the public and the trade before including any item on the schedule. Correct. Yes, please continue. Part 2A, page 52 of the markup copy. That's a clause 29, adding parts 2A and 2B, provision of specified health data to e-health system by specified healthcare providers. The Commissioner will be empowered to specify mandatory information or health data to be provided by the healthcare providers so as to enhance the comprehensiveness of the e-health record. So first of all, Section 26P, interpretation of Part 2A. It defines certain terms. Now, the consent of the healthcare recipients is necessary. So after streamlining the consent mechanism, upon giving the joining mechanism, the joining consent, then data can be uploaded onto eHealth. So the sections 11 and 16 of the 2025 Amendment Ordinance will specify the commencement date. That's the date on which the sessions come into operation. Now, for sharing consent in relation to a specified healthcare provider, it means a sharing consent given to the healthcare provider by a registered healthcare recipient under the former Section 12 before the commencement date. The same goes for the joining consent. There is also a definition for the former Section 12. It means Section 12 as enforced immediately before the commencement date. If there are no questions, we will move on to Section 26Q. Provision of specified health data to e-health system by specified healthcare providers. Subsection 1. Defining healthcare providers. They are described in column 4 of Schedule 3. They must be healthcare providers in Hong Kong and there are healthcare providers given sharing consents and joining consents by the patients to process the health data of the recipients. And also, the specified healthcare provider must provide to the e-health system in the form and manner specified by the Commissioner, and within the period specified, the health data of the healthcare recipients. Subsection 3, healthcare data health data of the healthcare recipients are those described in column 2 of Schedule 3. Subsection 4, the period specified in column 3 of that schedule opposite to the data. So there will be a schedule specifying the name of the healthcare providers, the kind of healthcare data to be provided, and also the specified period. At the moment, the schedule is still empty. In the future, by way of subsidiary legislation, we will fill in the schedule. And this applies to Hong Kong healthcare providers instead of non-Hong Kong healthcare providers. Ms. Carmen Kan. Thank you. May I suggest the administration to include an example in the bill? Now, the interpretation and Section 26Q, in the future, the Schedule 3 and Schedule 2 will be filled out by way of subsidiary legislation in the future. Now, for our benefit, I think you need to give us an example. Joining consents and sharing consents and specified healthcare providers and registered healthcare recipients, the same set of definition applies. But without examples, it's rather difficult to distinguish joining consents and sharing consents within the private sector. We follow what you are saying in the public sector. However, we need an example for the private sector. Now, on Schedule 3, let's say the health data may include those critical health data mentioned in the PowerPoint. Now, one of them may be allergy for medicine or radiologist reports. So if you provide some examples on the schedule, it may help. Ms. Erica Lam. Thank you, Ms. Carmen Kan. Now, by way of example, on the schedule, there are 3 columns. Let's say there is a healthcare provider, for example, the 13 private hospitals in Hong Kong. Then the specified health data may include a chemistry's reports, and then specified period, the length of the period, and then the schedule will apply to the 13 private hospitals. Then the system will automatically remind the private hospitals that a certain patient has given joining consent. So for these patients, the private hospitals will have to upload the chemist reports to eHealth after they have a result. So it wants to make the entire process as seamless as possible. Interfacing has already taken place between eHealth and the private hospitals. So as long as a joining consent has been given, the reports will be uploaded to the eHealth account automatically. So what's the difference before and after? There is a difference. Now, under the existing legislation, to upload data onto eHealth accounts, the sharing consent is necessary. That's before. Now, before the bill is introduced, there is already a significant number of patients already given sharing data. So where is this mechanism mentioned in the existing ordinance? About the arrangement between joining consent and sharing consent. When we were discussing section 10 and 11 in previous meetings, we have already covered the pre and post of the mechanism. Now, in the future, by way of subsidiary legislation, we will prescribe the commencement date. Now, in a subsequent provision, there is a transitional clause defining the commencement date. So when the patient gave the joining consent and sharing consent, they expect the healthcare providers to upload their health data onto eHealth. So there will be a transitional period. Now, after the bill has taken effect, a joining consent will mean a sharing consent. So for the recognized healthcare providers recognized by the Commissioner, they will be allowed to upload health data onto eHealth as well. So that's why you need definition like the former section 12 and also the relevant joining consent and relevant sharing consent. So after the commencement of the bill, sharing consent is not required because joining consent will automatically means sharing consent as well. Dr. David Lam, thank you. Still on 26Q. Now for health data required to be uploaded on Schedule 3, will there be a cut-off date? For example, a date starting from which all health data must be uploaded onto eHealth. Now, if that's the case, let's say if you specified the 1st of January 2025 as the starting date, all health data of patients must be uploaded. However, there may be some patients who haven't joined eHealth prior to the 1st of January. So the critical date should be when the patient has not joined eHealth or when the sharing consent has not been given. So for these cases, what happened to health data before that cutoff date? Will those data be required to be uploaded as well? Thank you. Data input under various circumstances. There are two concepts at play here. Now, for specified health data, in principle, we would like to adopt a forward-looking approach because that would be easier to enforce. We are telling the public that from a certain day onward, all health data would be uploaded to eHealth, but we will provide for flexibility. There may be scenarios that we need to trace back to a certain period of time for health data. So Dr. Lam mentioned we should use the joining of eHealth as a cutoff date. So are we only requiring health data generated after the patient has joined eHealth to be uploaded? Now, that's not the case because we want to make the health record as comprehensive as possible. So after sharing consent is given, health data beforehand can also be uploaded. For example, allergy to medicine and other health record, other historical health record may also be uploaded. So we are not using the date of joining eHealth as a watershed.
I understand. As a doctor, I agree that the more detailed the data, the better. But As a member of the public, when we go to public hospitals, I'm sure that they would understand that they would think that their data from 30 years ago would be seen through the shared consent. But if they go to private doctors, private healthcare providers, and their data might not be shared. Well, I'm not saying that this is entirely accurate, but I'm just making an assumption. Would you actually allow in the future an option for healthcare recipients to actually have their data shared before they register for the e-health system? Some recipients may not want their data from many years before to be shared out. They may have followed a certain doctor for many years and they have details of past operations or surgeries that they do not want to share out to others. Well, our meeting should be adjourned at 6:30, and so in order to not to cut it off abruptly, I would like to go through 26 hours and then we would adjourn the meeting. Erica, we do have a flexibility today. Let's say a patient provides a consent, sharing consent to the healthcare provider. The healthcare provider can choose not to share out the details or the data. Many HCPs will only share out data after the registration of shared consent, and past exchange records would also be put up. There is a flexibility under the law. Once we move on to making this mandatory, then we will need to consider more thoroughly the records to be shared. And in principle, it would be easy to be forward-looking in data sharing. Actually, the patients do not understand the operations. Let's say when they join eHealth, they do not opt in or opt out of it. They may not know that their data has already been uploaded to the system. Patients have actually the decision not to have certain data shared out. We already see this situation in private clinics because without the sharing consent, the HCPs would not actually upload the data in future. No, well, regardless of public or private, HCPs would be able to upload all data. That is still not very clear to the patients because once our system becomes shared out, the settings of the system might automatically just share out all data, or all data since the day of registration might be shared out. Well, this should actually be made known to the recipients because patients may actually not want their past records to be shared. Could they actually have such an option? I hope that you will make this clear. Otherwise, patients might actually be fearful that all their records would be shown without their consent. I hope you would be able to make this clear to the public. Oh, thank you. We understand because we're talking about 2 tiers of work we needed to do on publicity and education. We have to send out a clear message to HCPs and HCRs what it means by giving their sharing consent and how the records would be shared. We would work on that through our apps and also through our communication with the public. Through our collaborations with HCPs, we would also ask them to make it clear to the public on what they what it entitles when you give sharing consent. When recipients make it clear that they don't want to share certain data, we are looking at technology right now to see whether they could check off or opt out of certain sharing data. We are exploring different options at the moment, and we would also discuss with the operators on whether it could be feasible. And we want to ensure that there won't be too many conflicts rising out from sharing consent. Well, yes, I think you should also educate the public. Well, I have another question on 26Q. Let's take a look at 1B in the English. Is in possession of the health data of a registered healthcare recipient specified in subsection 3. When I look at this the first time, I thought that this is referring to the registered healthcare recipient and not the data. But then my understanding is that you're referring to the category or type of data and not a list of HCPs. So you might actually have to put the bracket after data and not after recipient. There's also the same problem in Chinese. Please take a look at it as well. It also occurs in subsection 2 because it seems like we're referring to data and not the providers. And so you might have to make this clearer in both the Chinese and English. Well, we would ask the legal advisor to take a look at it as well. Thank you. Dr. Lam, you have raised this before. We understand. We could just cross out the healthcare provider and then just refer it back to 1B, and that might make it clearer. We would work together with the DOJ to see whether we could make this easier to understand. All right, 26R. 26R on enforcement notice. If the commissioner is of the opinion that a specified healthcare provider has contravened Section 26Q on providing data, then the commissioner may give the healthcare provider a notice inviting, directing the healthcare provider to provide the specified health data stated in the notice by the date. The notice must state the opinion of the commissioner and also the reason for the opinion, and also state the specified health data to which the contravention of this section relates to and the registered healthcare recipient to whom such health data relates, and state the date by which and the form and manner in which the specified health data must be provided and be accompanied by a copy of this section. Subsection 3 also states that the date stated under subsection 2C must be a date that is not earlier than the expiry of the period specified in section 56(3), within under which an appeal against a notice may be made under section 56(1), and the date should not be shorter than 28 days, so that the healthcare provider can also make an appeal. The commissioner may cancel or amend an enforcement notice by another notice inviting given to the specified healthcare provider. We want to allow a bit of flexibility. Let's say we stated a date by which the healthcare provider must provide the specified health data, and the healthcare provider might say that it's a technical issue and he needs a bit more time, and we believe that the commissioner can then amend or cancel the enforcement notice so that the healthcare provider can register the data as soon as possible. Ms. Doreen Call. Chairman, page 54, English, B2. Go back and take a look. You said that such healthcare data relates, but then I see that health data you usually use plural. Can you go back and check it? For example, on page 53, the health data you refers to the data being plural and not in the singular form. Well, we will discuss this with the DOJ. Oh, Miss, well, do I need to extend the meeting? Well, I'll extend the meeting by 15 minutes. Ms. Carmen Ken, thank you. Specified health data is not defined here. Instead, it's defined under interpretation. And this refers to 26Q3. So the health data would be in the second column under Schedule 3. So there is actually no definition of health data made here. It just depends on what is under column 2 of Schedule 3. Because under 26R, under the enforcement notice for the healthcare provider would be that the provider must need to provide specified health data. Well, we do have a definition for specified health data. That would be the health condition of the recipient. But for this part, we are referring to specified health data, which would then be listed out clearly in our schedule. Is this not in the blue bill? If you can go back to page 3 of the marked up copy, there's actually a definition of health data. It seems that so you just defined what you mean by specified data or health data under the different clauses. Oh yes, and then for specified health data, this clearly means the data under Schedule 3. In the current e-health system, we actually would categorize the different data under different data domain. And that can actually help us understand it clearly. So our healthcare providers would be very familiar with it since they've been using it for a long time. Dr. David Lam, 26R and 47A, 47B, and 47C are all closely related. If the commission in English, if the commission is of the opinion that specified healthcare provider ... Here it says that if the commissioner is of the opinion, it seems that it's a bit simple because when you're trying to enforce someone to do it, you do have the reason to believe. Should you actually give the burden of proof to the commissioner, you can't just say that you just rely on the opinion of the commissioner. So I think that if you write has the reason to believe would be much better than is of the opinion. Thank you for your suggestion. You did mention it before. We have drawn reference from many enforcement notice, and one of which is CAP 484, the privacy ordinance. Well, I think that we can add in that if the commissioner, after investigation, believes that it is true, will issue an enforcement notice. I think that might be more appropriate because generally speaking, it has to be on complaint that a recipient might not find the data and lodges a complaint to the commissioner, and then the commissioner will then issue a notice in writing. All right. The commissioner issues a notice. The recipient didn't want the data to be shared before. So can it be a defense afterwards? I don't think it should be a defense afterwards because there should actually be a requirement to be complied before the notice is issued. And then I think that the recipient may actually be innocent, and yet you are bringing this case to the court. So this is like similar to the abuse of children, in which we discussed earlier. Well, when an institute may not actually have the capability to upload or input the data because they may not have a computer system, and so they may not be able to upload or share the data. So that is a problem as well.
I understand the doctor's concern. The policy intent behind the enforcement notice is to offer a tool to this Commissioner for Electronic Health Record to require the healthcare providers to fulfill the requirements. Upon fulfillment of the requirements, the purpose of the notice would have been served. There will be no follow-up actions. Now, on complaints, the Commissioner will have to take actions to investigate before issuance of the enforcement notice. The investigation will have to do with communicating with the healthcare provider, and whether we should specify the requirements concerning the investigation in the provision. Now that would be equivalent to subsection 2, that is the Commissioner to confirm whether due diligence has been made. So if the Commissioner is unsure whether due diligence has been made, the Commissioner may be simply seeking to ask the healthcare provider to upload the data. So that's why we are drafting the provision as it is, to provide for some flexibility for the Commissioner to interact with the healthcare provider. Now let's say if an enforcement notice is issued and the healthcare provider tells me that the patient asked me not to upload the data, then the Commissioner can revoke or withdraw the enforcement notice or amend the notice. That's the design of the mechanism. I don't have any follow-up question at this stage. I will ask my question when it comes to session 47. Legal advisor, please. Thank you, Chairman. We have sent a letter to the administration to inquire the proposed amendments to Section 26R. How will it affect the legal power of the original enforcement notice? Now the paper is CB brackets 3540 2025 brackets 1 in paragraph 9. Now the government's reply is set out in the reply letter CB brackets 360 608 brackets 3 paragraph 13. So I would like the administration to explain the reply to members. Thank you. There are two parts of the question. First, after amending the enforcement notice, what will be the legal power of the original enforcement notice? Well, the original enforcement notice would lapse. Now, after a new enforcement notice is issued, now in subsection 3, you mentioned that there is a 28-day appeal period according to section 56 brackets 3. The date will start counting from the date when the new enforcement notice is issued. Ms. Carmen Khan has pressed the button again. Now, in response to the reply given by the administration, do we need to specify the circumstances in the provision about the effect on the original enforcement notice maybe it would be better to spell it out clearly in the law. You need to clarify your policy intent in the provision. We will study the members' suggestion. Now I will adjourn the meeting. On the next occasion, we will start from Part 2B, page 55 of the markup copy. The next meeting is scheduled at 8:30 a.m. on the 2nd of June this year. A notice will be sent to members in due course. Thank you.